Thank you everyone for being here today. Just as a public announcement, your exits are to your right and to your left. And be sure to exit safely and softly should we have any kind of an emergency event. Thank you so much.
Welcome, everyone, and thank you for joining us today for the surgical illustration presentation by the class of 2022. I'm Corey Sandone. I'm the director of the Department of Art as Applied to Medicine and the course director for surgical illustration. We have 6 students, and they've each observed and sketched dozens of procedures, and they're going to present two, each is going to present 2 today. First, they'll show you a series of pencil sketches they developed to describe the steps of the procedure. Then they'll show their final artwork in one of the figures in the series. And in a related assignment, the students depicted the same procedure for patient education projects. You'll see some of these designed for a lay audience included in their presentations. Overall, the work you'll see today is designed to teach the operative steps to an audience of surgeons, residents, and fellows. After the student presents each piece, we encourage your feedback on the accuracy, clarity, and effectiveness of the images. I want to thank everyone who helped the students achieve success in this course, our faculty, the surgeons, residents, and fellows who welcomed the students to observe their cases, reviewed sketches, and explained the procedures further, and the OR staff who facilitated our students observing cases in Zayed, Weinberg, and the Jayhawk ORs. This opportunity and your participation makes surgical illustration one of the strongest courses in our graduate program in medical illustration. I also want to welcome our remote audience who's joining us via YouTube. Welcome everyone. Our first presenter is Shirley Lee.
Thank you, Corey, for the introduction. My name is Shirley. The first procedure I'm presenting is a robotic partial nephrectomy. I would like to thank Dr. Singla for the opportunity to observe and receive your feedback. Excuse me. In this case, a renal mass is observed on the anterior upper pole of the right kidney. Figure 1A shows the position of the patient, highlighting the port's placement. Figure 1B depicts the location of the tumor with dashed lines representing the dissection performed to expose the right kidney. In Figure 2, the renal hilum is exposed. A vascular variation at the hilum is observed, which involves 3 renal veins and 2 renal arteries. The normal hilar anatomy is shown in the inset on the bottom right. One of the renal veins is clipped and divided for access to renal arteries. Silhouette of kidney is shown to indicate kidney position. A circumferential incision was made on the gyrus fascia and renal fat to expose the tumor. And in Figure 4, kidney parenchyma is exposed. Oops. The border of the tumor is identified with an ultrasound probe and marked with electrocautery. The 2 renal arteries are then clamped using 2 bulldog clamps to minimize blood loss during tumor resection. Again, the bottom right inset shows artery clamping under normal vascular anatomy. In Figure 5, tumor was resected by cutting sharply into the parenchyma around the tumor following electrocautery marks. The closure begins with a series of V-lock running sutures being placed over the surface of the wound to achieve hemostasis, as shown in figure 6A. Hemodoc clips are used to anchor the sutures. The Bodoc clamps on the arteries are then removed. Figure 6B shows the renal capsule sutures being placed across the defect. 6C shows the placement of absorbable bolsters over the defect for hemostasis and compression. Then the capsular sutures are tightened. And finally, the gyrotest fascia is reapproximated as shown in 7A, where underlying kidney is shown in silhouette. Inset B shows the removal of specimen with an endocatch bag. And inset C shows the extended incision for specimen removal, indicated with a dashed line. For my final illustration, I chose to render step 3 in full color using a combination of watercolor and Photoshop, where the extent of the tumor is marked and renal arteries are clamped. This piece is designed in a slide format for surgical residents. I decided to use central lighting to highlight both actions in this illustration. Thank you, and I now open up to any questions and comments. Yes, Jenny.
I was just going to compliment you on, I know this is, kind of easier, and I'm really impressed with your use of the media. So one of the things I wanted to compliment you on is, your sketches actually look very finished and polished. I almost feel like they could be published like that, even though they're sketches. I thought they were just very fantastic. Great. Great job.
Thank you, Jenny. Yes, Lydia.
I agree, it's a really beautiful piece. And was this primarily watercolor and then finished in Photoshop?
Yes, so the question was, was this piece primarily in watercolor and finished in Photoshop? My answer is yes. I used, I think 70% of this illustration is completed in watercolor, and the instrumentations were mainly done in Photoshop.
It's a beautiful, soft look to the piece. One thing I might do is just still around the hilum where all the vessels are coming together and the instrumentation is coming in.
Mm-hmm.
I might add just a little bit of extra line in Photoshop, just a darker line, because you have these beautiful fade colors all in use, and that would really punch up that area. Just some thin lines around the veins, arteries, and then probably a few of the clips.
Okay,
Just to differentiate them from the background.
sounds good. Thank you, Lydia. Yes.
Hi, Mark Duncan, surgical oncology. I'm actually taking a contrary view because I would commend this because this looks like what the surgeon sees. This is how it looks to us, and you know the vessels do not look as black and white or red and blue as another picture would look like. So your call maybe will look better highlighted. It might be artistically better. However, this is kind of what it looks like. The vessels aren't as distinct as any atlas will ever make you think. So I'm more a fan of this style. And your chair, Corey, and others changed the game with text and atlases of surgery that actually look like what a surgeon sees as opposed to pen and ink drawings.
Oh, just to clarify, I wasn't suggesting a thick line, but just for,
Yeah.
for clarity purposes, not for artistic purposes. In fact, I think this is more
I'm not
beautiful.
arguing with the artist.
Yeah, no, I think this is more beautiful actually, but for clarity purposes, for somebody who's learning the procedure and maybe not wanting to see a photographic representation of it, that would be my recommendation.
Thank you for the comments.
Just a comment from you two. Dr. Singla says, excellent presentation, it's very accurate, and apologizes for not being able to attend in person. And a really beautiful illustration from Emmy Simpson. I will ask everyone in the audience to please speak up more than you think you need to, just for our audience online. We apologize, we don't have other microphones for you, but thank you.
Thank you so much, Dr. Singla.
Storage also says, awesome illustration. Love your treatment for cauterized tissue and clamped vessels.
Thank you, Sora. Yeah. And if that's all for the comments, and yes, Ron.
I just wanted to comment that I really like how you inserted that inset there to show the normal hilar anatomy, recognizing that that's not always what you're gonna see. You've done a great job of exposing what's going on at the vessel layer, as well as what the action that's happening up above, and the two work well together. Those two moments of time are represented really good.
Thank you, Ron. I think I will move on to my second procedure. The second procedure I'm presenting is a lumbar laminectomy for spinal epidural arterial venous fistula, or AV fistula. I would like to thank Dr. Jackson for accommodating me and for all of his feedback. A spinal epidural AV fistula is an abnormal connection between arteries and veins in the epidural space that may cause damage to the spinal cord when high-pressure arterial blood enters spinal veins. In this patient education piece, the fistula is shown in purple, characterized by the swollen venous structure. In this case, the fistula is located at L5 level ventrally. In figure 1, the patient is positioned prone. A midline incision was made to expose L4, L5, and S1 laminae. And first, supraspinous ligament is incised, followed by L4, L5, and S1 laminectomy. The dashed line on the left image indicates a portion of laminae being resected. An inset on the top right shows laminectomy in an axial view. The image to the right shows the exposure of the thecal sac. The laminectomy is widened and parts of the ligamentum flavum is resected. Then the thecal sac is retracted to expose the AV fistula, with the main arterial feeders coming from the right L4 retrocorporeal artery. Arterial flow to the fistula is interrupted by cauterizing the L4 feeders. The dura is then opened to access the radiculomedullary vein that had been receiving arterial blood. Dissection of dura and arachnoid is performed as shown in figure 4. The radiculomedullary vein is cauterized using a bipolar. This prevents future arterial reflux in the case that arterial feeders reopens the fistula. This image highlights the interconnected epidural and intradural venous networks to depict the lesion's architecture. After disruption of the radiculomedullary vein, the dura is closed with running suture. And finally, a laminoplasty is performed, followed by wound closure. For my final illustration, I chose to render step 5, which depicts the full architecture of the epidural AV fistula after the arterial feeders have been cauterized. This piece is formatted for general cover. I used transparency to communicate the relationship of structures at different levels and to highlight the extradural and intradural components. An arrow is used to indicate the former pathway of arterial blood in the venous system prior to cauterization. And this concludes my presentation, and I now welcome any questions and comments. Thank you for your attention. Any questions, comments?
Another YouTube comment from Sophia Alexis. Amazing illustration, love your style and color combinations.
Thank you, Sophia. Yes, David.
Sure, I just want to compliment you on this piece. This is one of those pieces that really pushes the boundaries of what we do as illustrators. This is simply something you can't see in the OR, and you've captured a lot of the tissues, but you've also balanced that with some really effective color coding. And what's most noticeable and remarkable, I think, is your transparency, your ghosting, and being able to take people through the layers and really teach the anatomy plus the
Thank you, David. Yes, Tim.
I was also going to comment on color coding and the difficulty or the complexity of this surgical moment, and how in a sense you simplified it and are able to teach the audience, this particular moment in the surgery and the importance of all the structures that are there. It's a packed image, and you did a really marvelous job of clarifying and educating.
Thank you, Tim.
Couple other comments from YouTube, just from Jessica. The final piece is gorgeous. You have wonderful rendering. Sophia again says this is such a special case, great depiction and style. Emily Slavin says beautiful work. And Emmy Simpson says, I really like this piece. You managed many complicated elements very well.
Thank you so much, all. Yeah, I really appreciate the comments and feedback. I will move on, and I will now like to introduce my classmates, Jason Brady.
Well, thanks for the introduction, Shirley. Hello, my name is Jason Brady, and I will be presenting a Cesarean hysterectomy. Thanks to Dr. Vaught for allowing me to observe the case. This is meant for obstetricians who may not be as familiar with the condition known as placenta accreta. Placenta accreta spectrum is a condition where the placenta is abnormally attached to the uterus and will not safely detach after delivery. Figure 1 illustrates imaging revealing the placenta accreta, in which the placenta invades through the myometrium and possibly into the bladder. To perform cesarean, Figure 2 shows the initial vertical incision is made in the abdomen and a transfundal incision on the uterus is made to avoid the low-lying placenta. Once the baby is delivered, the umbilical cord is doubly clamped and divided. The placenta is left in the uterus since removing it manually would cause a massive hemorrhage. The hysterotomy is sutured with running, walking sutures. This is the relevant vasculature that will be ligated: the ovarian artery, Samson's artery, and the uterine artery. The uterus must be avoided as they run inferior and lateral to the uterine arteries. First, long Kelly clamps are placed on the cornua of the uterus. The round ligament is suture ligated and divided. A window in the broad ligament is created. In Figure 6, the uterine tube and uterovarian ligament are suture ligated and divided with a ligature. A salpingectomy along the dashed line resects the uterine tube. Figure 6b illustrates how the ovary is spared. In Figure 7, the posterior leaf of the broad ligament is divided. The ureters are identified to be out of the surgical field. The uterosacral ligaments are then divided. In Figure 8, the anterior leaf of the broad ligament is divided, lateral to medial. In Figure 9, a bladder flap is created from the anterior leaf. Adhesins are dissected to create a plane between the lower uterine segment and the urinary bladder. In Figure 10, the uterine vessels are ligated and sutured. Care is taken to avoid the ureters. In Figure 11, the cervix is doubly clamped and divided, and the edges of the vagina are transfixed and the cuff is sutured. I chose to illustrate the dissection between the lower uterine segment and the urinary bladder, as this is a crucial step in the procedure, as there is an increased risk of hemorrhage in this area. This also demonstrates how previous cesarean deliveries cause scar tissue, which increases the risk of an abnormally adherent placenta. The percarita was painted to show its translucency to demonstrate the placenta has invaded through the myometrium and is only contained by the thin serosal layer of the uterus. Thanks for your attention. I now open this up to any questions and comments. One question from Tim.
One thing that the audience can't appreciate in this particular image is the atmospheric perspective you were able to achieve with the clamps and the structures sort of in the background and bringing our attention forward. I think the color palette is excellent, and the drama that you
Cool. Thanks, Tim. David with a question.
Jason, very nicely done. I really appreciate, especially in your sketches, but also in the finished piece, how you were able to capture very effective tissue reaction and lifelike tissue texture. But you didn't go too far. I think that you really did a great job of still keeping people focused on the vessels that you wanted to show and the main structure. So I feel like you had a very nice balance between realism and a didactic, clear series of sketches.
Awesome. Thanks, David. Lydia with a question.
I was just wondering if you, for the audience out there who might not be familiar with this, could you talk a little bit about how the Cesarean section relates to the percratum? Because it's nice that you combine the adhesions and the percratum in one image.
You mean the
Yeah, like the cause and effect.
like the hysterotomy, the initial hysterotomy? Usually, cesarean deliveries are made at like a lower horizontal incision, kind of where all those adhesions are, and that causes the implantation to occur in that area, which then causes the invasion of the placenta. So that's why in these you need to go with a transfundal going through the top, leaving the placenta in place. Otherwise, if you hit that area, it's going to cause a lot of bleeding. Cool. And Juan with a comment or question.
It's more of an artistic comment. Maybe I think the image is very straightforward, very beautifully rendered. I really love those highlights on the placenta percratum. Given that the main point here is removing those adhesions, I wonder if some of that beautiful treatment that you did on the placenta percratum could be done along the adhesion points to bring a little bit more drama to the area of focus here. Also, perhaps a little bit more drama to the instrument itself, that hemostat that's doing the splitting, maybe bringing down to that area of focus. So again, everything is beautifully rendered. I wonder if it could be tightened up a little bit more to emphasize the moment of focus.
Yeah, that makes sense. Thanks for the comments. Just to bring focus more to the adhesions, if the viewers at home can't hear.
2 comments from YouTube, 3 comments actually. Emmy Simpson says, I agree with Tim, really great and realistic core palette. She especially loves the detailing on the, I'm going to say it wrong, but the ascenta percreta? Okay, yeah.
Good enough.
You guys know what I mean, right? And Story G says, I love how I can feel the thickness of the bladder flap. The highlights on the flap give a great feel of the tissue. Awesome. And Emmy corrected herself and said, realistic color palette is what she meant. Got it? And Levent FA says, very balanced piece, great color palette.
Cool. Thanks. I'm going to move on then. Thanks for all the comments and everything. Cool. So now I'm going to make a transition to the tiniest bone in the human body. The next surgery is a stapedectomy, and many thanks to Dr. Stewart for allowing me to observe the procedure, and Dr. Brian Dunham for his excellent feedback on the sketches. So figure 1A illustrates the ossicles, which amplify sound waves, transmitting them to the cochlea's oval window. Figure 1B depicts otosclerosis, a condition where abnormal bone remodeling causes the stapes to become fixated in the oval window, restricting the movement of the ossicles and causing hearing loss. The left ear was operated on with the patient in a supine position. Figure B displays the tympanic membrane and surrounding anatomy. Figure C is a coronal cross-section, giving a bird's eye view of the position of the ossicles in the middle ear. An initial incision with a round knife is created 6 millimeters from the tympanic membrane. The tympanomeatal flap is pushed medially, revealing the scutum bone beneath, and a pick is used to free the annulus and divide the mucosa and elevate the flap. And then this is a view of the endoscope in the middle ear cavity. The chorda tympani is a branch of the facial nerve lateral to the incus, and care is taken to not damage this nerve. A curette is then used to remove the scutum to increase surgical access, although this is not always necessary with an endoscope. Labels in bold will subsequently be divided to remove the stapes superstructure.
Jason, a little louder, please.
Sure. In figure 5, a joint knife separates the incustupedial joint. In figure 6, a laser divides the tendon of the stapedius muscle. This muscle resides within the bony pyramidal eminence. In figure 7, the posterior cruce is divided with the laser. The endoscope allows for improved visualization of the anterior cruce, so it could then be divided with the laser in step 8. In figure 9, the stapes superstructure is removed with a suction, while the footplate is left within the oval window. A measurement is taken from the incus to the footplate to determine the length of the prosthesis, usually being 4.5 millimeters. A laser then creates a rosette pattern on the footplate. A hand drill is used to create a fenestra in the footplate with a diameter of 0.6 millimeters to accommodate the piston of the prosthesis. The piston of the prosthesis is inserted into the fenestra of the footplate while the shepherd's hook is placed on the incus. A laser is used to heat the nitinol hook, causing it to tighten securely around the incus. Finally, my favorite part of the procedure is creation of the blood patch by abrading vessels on the promontory to seal the piston around the stapedectomy. I rendered the removal of the stapes superstructure, which was the opportunity to show the stapes from a different perspective. Instructional colors draw attention to the otosclerosis, chorda tympani, and differentiates the tendon from the bone. I also created an illustration to depict the morphology of the middle ear and the orientation of the ossicles, especially how the stapes fits in the oval window, as well as its relationship to the otosclerosis, cochlea, facial nerve, and pyramidal eminence. The anterior cruce is being targeted, while the posterior cruce and stapedius tendon have already been divided. Thank you for your attention. I now open it up to comments and questions. Question from Laura.
I love this space. This is wonderful. I just wanted to say that I personally have not seen a lot of lasers surgical illustration before. And I think my mind would have gone green. I'm sure that is more accurate. I just wanted to compliment you on like how it really reads like a laser. Like I know it's not just you are doing it anything else. But I just thought it was very cool.
Oh, thanks. I did do a little like artistic stylization of the laser for drama, but thanks. Question from Lydia.
I was just curious, do you think about adding a little bit of trabeculae in the bone just to sort of highlight the osseous labyrinth and how that might differentiate from where you would see more trabeculae on that right side of the image? The mastoid and air cells and things.
Yeah, I was thinking, so the question was to add more trabeculae around the bone cut. Right now I just have like a very subtle pattern just to focus your attention on like the middle ear, external meatus, and the cochlea, but I could add some. I was kind of referencing how Broidel, he played it more, but he had like a subtle pattern in the trabeculae, so I could adjust that. Thanks for the, yeah.
Comment from Emmy Simpson on YouTube. Really interesting procedure. She imagines it's one that can really benefit from being illustrated. So.
Oh, we're good. All right, cool. Thanks for all the comments and questions. Now to introduce the next illustrator, it's a pleasure to introduce Jennifer.
Hi everyone, thanks for the introduction, Jason. My name is Jennifer Wang, and the first surgery I will be presenting today is a pancreaticoduodenectomy, also known as a Whipple, which is performed to resect tumors that arise in the head of the pancreas. Thank you to Dr. He for the opportunity to observe in his OR and for all of his feedback during this illustration process. Before resection begins, the patient's abdomen is explored laparoscopically to assess for any tumor metastasis that would preclude the continuation of this procedure. A midline abdominal incision is made from the xiphoid process to just below the umbilicus. The specimen excised during a Whipple includes the head of the pancreas where the tumor is located, the duodenum, and the gallbladder. Once the abdomen has been opened, the omentum is detached from the greater curvature of the stomach using electric cautery. The exposed right gastric and right epiploic arteries are then ligated and transected. The antrum of the stomach is then divided using a GIA stapler. Next, the gastroduodenal artery and the hepatic duct are identified and divided. A Coker maneuver is performed to detach the lateral peritoneal attachments of the duodenum, and the ligament of Treitz is transected to mobilize the jejunum. The jejunum is then pulled through the divided ligament of Treitz defect and transected using the GIA stapler. The pancreas neck can then be cauterized and transected. The inferior pancreaticoduodenal artery is ligated and transected, and finally the uncinate process of the pancreas is mobilized. Once the specimen is removed from the field, the borders of an anatomic triangle, as defined by the common hepatic artery and celiac trunk, the superior mesenteric artery, and the portal vein and superior mesenteric vein, are assessed to ensure that all tumorous tissue has been resected. The pancreas is reattached to the jejunum through a duct to mucosa pancreaticoduodenestomy, where a small enterostomy is anastomosed to the pancreatic duct. If the pancreas is particularly fibrosed, only one layer of running sutures may be needed, as shown here in these sketches. The hepatic duct is reattached through a hepaticoduodenostomy, and the stomach is then reattached through an anticolic gastrojejunostomy. For my final illustration, I chose to render step 8 and step 9. This is how they could look laid out in a surgical atlas. Step 8 highlights the shared blood supply between the duodenum and the head of the pancreas, which is why the duodenum is one of the structures that is also resected during a Whipple. I chose a color palette using instructional color to differentiate between the vessels and the important surrounding structures. I rendered the tumor using a lighter color to emphasize the tumorous tissue compared to the healthy pancreatic parenchyma, and the instruments and sutures are oriented in a way to direct the viewer's attention to the area of action where the IPDA is about to be transected. Thank you, and I now welcome any questions or comments. Yes.
I have an anatomic question now. It's hard to make any comment when John Cameron was just here, who, has done over 2,000 of these procedures and more than any other surgeon. And he was the one who hired me 25 years ago. But, comparing illustration 8 and 9A, the pancreatic duct has enlarged considerably.
Mm-hmm.
And that renders the illustration easier to understand, but the reality of the suturing is much closer to figure 8, where the pancreatic duct is not that large compared to the rest of the pancreas.
Mm-hmm. Sorry, what was the question?
So the question or the critique is that your pancreatic duct in 9A and 9B is markedly more dilated than it is in figure 8.
Yes. Yes, so the question was that the duct is slightly more dilated in figures 9A and 9B compared to figure 8. So when I was showing the anastomosis, I was trying to show a more fibrosed pancreas where there's less pancreatic parenchyma left. So you'd only need one layer of sutures instead of 2 to connect the duct to the mucosa. Yeah, David?
Jennifer, I think that was a really great observation anatomically, and I think the size that you have the duct right now is great because you're able to really see what you were just mentioning, the detail of the suture and the anastomosis. I'd hate to see it go smaller, but I agree with the observation of the anatomical differences.
Mm-hmm.
So I would hope that you would just enlarge the surrounding tissue and not go smaller.
Yeah.
Because it's so important.
Okay, yeah. Oh, sorry. Yes, Jenny.
I was just gonna make a comment about, how clear and, I feel like the color choices that you used are very exacting, and showing there's so many structures to see. One suggestion I had was on your, smaller vasculature that's divided, is to add a little bit more contrast there as opposed to, main trunk, so that it's a little more noticeable.
The ones that are already cut?
Yeah.
Okay. Thanks, Jenny. Yes, Juan?
I just want to commend you on the sophisticated sketches. There's so much information there, and it was just so beautifully rendered. There was a lot of incorporation of different structures that have to be accounted for in those images. So I want to commend you on the sophistication of the piece. In this particular rendering, I'm wondering if you can point to where the connection point between the nephrectomy pancreas and the jejunum would have been on the, where is the site? Is it right there, right around where the tumor is, where the lung would be?
So in this illustration, so the question was where the reconnection of the neck of the pancreas would be to the jejunum. So in this illustration, step 8, this is actually part of the duodenum that would be taken out, and the part of the jejunum would be pulled. So it's not shown in this illustration, but it would be pulled through this ligament of Treitz defect to be able to be reattached.
That accounts for my question. I was looking for where it would be reattached.
Yeah. Thank you for all the comments and questions. I'm going to move on to my next procedure. So the second surgery I'll be presenting today is a right supine craniotomy for tumor resection. I'd like to thank Dr. Bettigauda for giving me the opportunity to observe in his OR and for all of his feedback during this process. So the patient is placed in a supine position and their head is anchored in a 3-point fixation using a Mayfield head holder. The incision line and craniotomy approximation are determined based on the location of the tumor. In this case, the tumor is located in the patient's right hemisphere. Once the initial incision has been made, Raney clips are placed around the edge of the incision for hemostasis. In Figure 2, a neurodrill is used to create 2 burr holes, and a Penfield dissector is used to detach the dura from the skull under the burr holes. Figure 2a illustrates the dural dissection from a coronal view to demonstrate the depth the dissector reaches under the skull. In Figure 3, the craniotomy flap is completed using a craniotome to cut around the edge of the approximation. The dura is then opened in a cruciate fashion, and dural tenting sutures are placed at the borders of the craniotomy to keep the dura adhered to the skull and prevent epidural hematomas post-procedure. An electrode strip is then used to determine the location of the tumor in relation to the motor cortex. As shown in Figure 5a, the tumor in this case was located in the supplementary motor cortex, just anterior to the primary motor cortex. Figure 5b illustrates the location of the tumor in relation to the longitudinal fissure between the 2 hemispheres. Next, a corticectomy is performed to open the cortex and gain access to the tumor. The tumor is mobilized using a combination of bipolar cautery and microscissors around the borders of the tumorous tissue. Figure 7 depicts the tumor internally debulked with an ultrasonic aspirator. The debulked tumor and tumor capsule are fully resected using bipolar cautery to check for any local bleeding. Avitine gel is used to pack the wound for further hemostasis before closing. Finally, the dura is closed with simple interrupted sutures, and a gel film pad is placed between the dura and the craniotomy flap. The flap is reattached using burr hole covers and cranial plates, and the incision is closed with subcutaneous sutures and staples. For my final illustration, I finished Figure 8 and 8a and designed these steps how they might appear in a slide presentation for neurosurgical residents. I chose to leave the borders of the incision grayscale and transition to a centrally focused rendering with a higher saturation of color to highlight where the tumor is being excised. For instructional purposes, I used a simplified coronal section in the inset that is not a typical surgical field view to visualize the depth of the tumor. Continoids would be placed around the entire border of the cortex, but most were omitted in this illustration to clearly show the different levels of dissection to have reached the tumor. Thank you, and I now welcome any comments or feedback.
So, you know, in the interest of time, we're not going to read off comments on YouTube. You're getting lots of great comments that we'll share with each of the students. But if there's any questions, we'll share those. Okay.
Lydia?
I don't have any question. I just wanted to say that the dura is just so beautifully rendered with all the pinks and purples that you've added into it, it just feels exactly like you see it in neurosurgery. And the cortical vessels look really convincing wrapped around the tumor. I think you've just done an excellent job integrating all of our feedback. Actually, for the audience, they probably don't know how many rounds of feedback you've gotten from the faculty. So you've just done an excellent job of integrating all that together.
Thanks, Lydia. David?
Jennifer, I want to compliment you on this, and in particular, your staring of the viewer with the saturation of color you really want them to look, and just the beautiful, very subtle vignetting of the support information that's not as important in this image. That's, you make it look effortless, but I know a lot of thought and trial and error goes into it, but you really pulled it off very nicely.
Thanks, David. Tim?
And you talk about this illustrative convention of that flat plane and then treating the mobilized tumor in 3D. I think that works really well. It's just another opportunity for what illustrators bring to artwork like this, that we can fool the eye, tell stories, and do great work.
Thanks, Tim. Thank you for everyone's comments and questions. I'd like to introduce my very talented classmate, Kelly.
Thank you for the introduction, Jennifer. My name is Kelly Lim. The first surgery I will be presenting today is mitral valve repair performed by Dr. Gami. Thank you, Dr. Gami, for the great opportunity to observe your surgery and for the feedback. The surgery was performed on a patient who had mitral valve regurgitation, which is a condition in which the mitral valve doesn't close tightly enough and causes backflow of blood from the left ventricle to the left atrium. One of the most common etiologies of mitral valve regurgitation is mitral valve prolapse secondary to pathological posterior leaflet, which was the case for this patient. The surgery began with a median sternotomy. The pericardium was opened and care was taken not to damage the phrenic nerve. Once the heart was exposed, cardiopulmonary bypass was connected and the heart was stopped. Then the mitral valve was exposed, which was done in 2 steps. First, the heart was lifted, then an incision was made in between the sulcus terminalis and the 2 pulmonary veins. A second incision was made to enter the left atrium, exposing the diseased valve. Normally, resection is avoided, but in this particular patient, there was such extensive hypertrophy of the posterior leaflet that a resection had to be performed. Remaining valve tissue was closed with simple interrupted sutures. To reinforce weakened chordae tendineae, which are the main culprit for mitral valve regurgitation, Gore-Tex neocords were replaced in the posterior leaflet. Cross-growth annuloplasty band was used to further tighten the valve. Finally, valve competence was checked with saline test. I decided to render step 7, which is the most important step in repairing mitral valve regurgitation. I omitted evidence of valve resection because mitral valves are ideally repaired with a resection. Dr. Gami explained 99% of his cases are done with a resection. I've included 3 insets which are labeled A, B, and C in chronological order. Inset A illustrates how the papillary muscle is pierced with figure of 8 technique, and inset B explains how the neocords are secured into the coaptation zone of the leaflet. C shows what the finished set would look like from the surgeon's view. In terms of rendering, I tried to stay somewhat realistic, but also use some bright didactic colors to create contrast between the neocords and the heart, making it easier for viewers to comprehend this complex step. I've labeled key structures and included an orienting figure to minimize confusion when this illustration is used as a standalone piece. I now welcome your comments and feedback. Okay, Juan.
Kelly, I really like the way that you helped orient me to the structures that you're working with the labeling of the P1, P2, P3, and make a clear connection between those. The P2 suture is so close to the color that you've chosen for the myocardium that it's kind of hard to pick up, especially that inset C. I'm wondering if a different color either to the myocardium or to that suture would be helpful to increase the visibility.
Okay, thank you for the comment, Juan. Yeah.
Kelly, I love your vibrant colors. You got your own style. It's very artobiotics. My one suggestion is the blue suture, similar to Juan's comment, is a little dark on dark. So if it's like a lighter blue, maybe it'll pop a little bit more.
Okay.
I love how clear all the sketches were.
Right.
Really nice colors in your sketches.
Thank you. Oh, yeah. Hi.
Really love your piece, and I like the composition of the image very much. I'm wondering if you could elaborate a little bit on your decision to put the inset A where it is, only because the I leads me first to the B, and if you're going from 6 o'clock to 11 o'clock to almost 1 o'clock on the whole layout. So did you think that through, and what was your thought process?
Yeah, so the question was, why did I decide to put A in the position that I placed it? Because the I first goes to B. Yeah, and I've decided to put the enter in the center because it is the same muscle as the anterolateral papillary muscle that I've drawn in B. So I kind of wanted to place A in line with B and just make it a bit enlarged to show the audience how it's pierced before step B is done. And because step B is much bigger piece than A, I kind of put it here so you can also directly compare it to step C. Because one of the most important keys is that you put the sutures in the coaptation zone. So I wanted to put B and C in line so you can see where the coaptation zone is in line in two different views. Yes.
I just wanted to compliment your problem solving with the yellow suture that's coming down. I mean, because I worked with you on this piece, and you did so many different iterations trying to figure out a way to loop that in 3D space. And it looks so simple and easy now to understand. But I think it's remarkable that nobody in the audience has asked you any questions about how it's tied off, because it's just done so clearly. So, compliments on that.
Thank you, Lydia, and thank you everyone for your comments. I will now move on to my second surgery, which is Nissen fundoplication with gastrostomy tube placement. It was performed by Dr. Capiello on an infant. Many thanks to Dr. Capiello for the opportunity to observe the surgery and for the great feedback. The surgery was performed because the patient was having feeding difficulties with a high risk of aspiration due to neurological deficits. The patient was first positioned with a roll under her diaphragm, and 4 ports were placed. This view is what the surgeons see when they first enter the abdominal cavity. The surgery began with the mobilization of the greater curvature of the stomach, which was done by dividing short gastric vessels. The hepatogastric ligament was then divided, beginning at pars flaccida, which is a thin membranous part of the hepatogastric ligament overlying the caudal lobe. Following the division of the hepatogastric ligament, the phrenoesophageal membrane was divided. Adhesions on the esophagus that were connecting it to the crawl opening were also removed. The phrenoesophageal membrane on the posterior esophagus was then divided. All these divisions led to the full exposure of the esophagus and the creation of the retroesophageal window. This particular patient had a mild hiatal defect, which was closed with 3 sutures: the orogastric tube in situ, helped the surgeons determine the location and the width of the esophagus. Fundoplication was then performed. The fundus was first brought to the other side of the esophagus through the retroesophageal window that's just been created. Then Schuschan maneuver was performed to ensure there was no twist or tension. Finally, both ends were brought to the center to create a loose wrap. After the wrap was secured, gastrostomy tube placement began. The stomach was first elevated to the abdominal wall, and a pair of sutures were placed in square configuration to hold it. A guide wire was then introduced, and the tract was dilated by Seldinger technique. Tube with a balloon bumper was introduced next. The balloon bumper was inflated, and both the gastrostomy tube and the stomach were secured in place by stem technique. I chose to render step 4, which shows all structures that have to be divided to get the right crus exposed. Pass flaccida first, then the rest of the hepatogastric ligament, followed by a phrenoesophageal membrane, which you need to retract the caudate lobe to have a good visual, and finally adhesions, all of which have to be divided above the left gastric artery. I chose this one because it is one of the most complicated steps in the surgery that's often not fully depicted in traditional surgical illustrations. I've tried to stay realistic, but given subtle didactic colors to the important structures so they're easily distinguishable, and given a bright right upper corner lighting to give this dynamic piece a theatrical atmosphere. I now welcome your comments and feedback. Yeah.
So I'd like to compliment you on the two styles that you've given us today, your sketches and this finished piece. The sketches just have such an appeal that they're, in a sense, non-threatening to perhaps patient education. And in a sense, in this piece, you kind of carried this further with your painting technique that seems sort of hinted at in your sketches and pushed it further into this dynamic image. Congratulations.
Thank you very much, team. Yeah.
So this is a very nice piece, really beautifully done. I agree with you also on your sketches, very clean, clear. My one comment here is the window that you created showing the crus and the incision is, and I think this came up earlier in process critiques, was a little bit light, and I think there were suggestions to darken it. I'm wondering if it's a little bit too dark now, because I think that you have an opportunity to show some of the muscle structure, the crus. And also depth, but maybe a little bit less of the depth and a little bit more of the anatomy.
Okay, thank you for the comment, David. Yeah.
Again, congratulations on a great series. I'm actually impressed to see that you colorized your sketches. Beautiful. Just going along with David's comment, I wonder if you might add a link to the incision that's inside the window, because it's still hard to see.
Okay.
And I think that will clarify that next time that we get to.
Thank you, Jenny. Yeah. Thank you so much. Okay, now I will introduce to my next classmate who's amazingly talented, Tina.
Thank you so much, Callie, for the introduction. So I'm Tina Wayne. And the first surgery I'll be presenting today is the hepatic artery aneurysm repair. Thank you so much, Dr. Black, for the opportunity to observe the surgery and for your feedback during the illustration process. So hepatic artery aneurysms are rare, accounting for about 0.1 to 2% of all arterial aneurysms. It is, however, associated with high mortality due to high risk of rupture. The repair surgery started with a right extended subcostal incision. The organs were retracted so the aneurysm and pancreas were visible. You could see the aneurysm extended from distal celiac trunk all the way to the hepatic artery bifurcation. Since the patient has had prior abdominal surgery, altered upper GI anatomy is depicted. The liver was retracted to reveal the bifurcation. Lesser omentum and vessels overlaying the aneurysms were divided and transected to expose the aneurysm. Celiac trunk and splenic artery were identified and isolated. Gastroduodenal artery could not be isolated without injuring the pancreas because it was behind the head of the pancreas. The bifurcation and celiac trunk and splenic artery were clamped down to control blood flow. The aneurysm was then opened up. Mural thrombi were evacuated to reveal opening into gastroduodenal artery, which was then ligated with a figure of 8 suture. When hemostasis had been fully achieved, the rest of the thrombi were removed. A dacron graft was parachuted into a ring of normal tissue into the into the celiac trunk proximally and the hepatic artery bifurcation distally. The aneurysm sac was reapproximated. Step 7 was illustrated. In step A and B were added to give more details regarding the anastomosis, but retained the same orientation as the main figure to maintain clarity. Thank you so much, and now I welcome any comments and questions. Thank you so much, Laura. David?
Tina, this is beautiful. Can you do me a favor? Can you go back to your sketch right before this and just flip? It was so much fun to see it because it's registered. And now we're final. I was just to see the two right after another. Really nice. The only thing I would say, I really like this too. She's done a beautiful job of, again, directing the viewer because you made some very sophisticated decisions about going darker in the periphery. And really, we packed a lot in here, but I can follow. I think we can follow. The only comment I have is if you could move your box A so that the dacron graft is not tangent with the under the edge of the lip. That's my eye goes right there. It's working into it. Other than that, I think it's just a beautiful piece.
Thank you, David. Thank you so much for all the comments and feedback, and now I will be moving on to my second surgery. So the second surgery I'm presenting today is a juvenile nasopharyngeal angiofibroma resection. Thank you so much, Dr. Gallia and Dr. Linden, for the opportunity to observe the surgery and for your feedback during the illustration process. So juvenile nasopharyngeal angiofibroma is a locally aggressive, histologically benign vascular neoplasm that occurs almost exclusively in adolescent males. The first slide shows the extent of the tumor. In figure 1, we could see the tumor is taking up almost the entire left nasal cavity, pressing laterally against the maxillary sinus, and spilling into the sphenoid sinus. Figure 2 shows a parasagittal cut. The tumor could be seen extending beyond the pterygoid palatine fossa into the infratemporal fossa, where it pushes anteriorly against the posterior wall of the maxillary sinus. The tumor was primarily fed by the sphenoid palatine artery and secondarily fed by the artery of pterygoid canal. For this series of illustrations, we're going to focus on resection of tumor in the infratemporal fossa. The approach taken was a combined endonasal endoscopic and sublabial transmaxillary approach. A medial maxillectomy was performed endonasally, where the middle turbinate, uncinate process, medial wall of the maxillary sinus, and posterior half of the inferior turbinate were resected. Nasolacrimal duct was preserved. Through the sublabial transmaxillary ostium, posterior wall of the maxillary sinus was removed. Figure 5b shows a surgical view through the ostium. The exposure is shown here. Medial portion of the tumor was resected to expose the artery of the pterygoid canal. The artery was transected so that the rest of the tumor could be mobilized in a medial direction. The tumor was freed from surrounding tissues and debulked prior to removal. And using a multi-handed technique, the tumor was pushed medially into the nasal cavity before being amputated and removed through the nostril. I decided to render step 9. Transparencies were used to show the different overlaying structures. Didactic colors were used to highlight the important structures. Teeth roots and infraorbital nerves were added to show that these structures needed to be preserved when making the transmaxillary ostium. Thank you so much for listening again, and now I welcome any comments and questions. Lydia?
I just said that I absolutely love the colors that you chose to differentiate all these layered structures through transparency. It's just so successful and so clear, and the almost glass-like treatment of the skin is working really well. One tiny little thing I just noticed when I was looking at it in the hallway, if you could add like a little bit of a glistening edge of some kind on the medial wall, maxillary sinuses and mucosa where it's been cut, I had to stare at that for just a little while to sort of figure out which side of it I was looking at almost. So if there were just some little indication of the fact that it had been sort of cut and it's sitting on the bone like a little bit almost, that would just make it even more clear than it is, which is already amazing. So excellent job.
Thank you, Lydia. It's Tim.
I'm really impressed with your limited palette here. It's almost a pastel drawing, and you used some accent outlining and some shading and shadow to certain areas to draw attention. It's really very, very nice.
Thank you, Tim. Jeff.
Really nice job figuring out a lot of complicated anatomy and showing us views that the camera can't see. So it's really helpful. And I also want to compliment you on your presentation. I appreciated you signaling us through one by one of your colors and labels that popped up one by one so we can follow it.
Thank you. Juan.
I think what was most impressive to me in the presentation was having that continual axial view image and having all the corresponding movements on that show. So that really, as a presentation guiding me through this process, was really effective.
Thank you, Juan.
This one image, the blue arrow, I'm a little confused what that's indicating. It's such a prominent point, and yet I don't understand if that's simply indicating this is the pathway that we will be removing the tumor. Is that?
So the question was to clarify the purpose of the blue arrow. So the blue arrow is to show the course of the tumor moving from the maxillary sinus into the nasal cavity, and then before being pulled out through the nostril.
I'm wondering if just a small extension through the nostril would be helpful so that I know this is where it's going out.
Okay, thank you so much for the comment. Jenny?
To that point, I think that what would be helpful is the little black arrow that's on your instrument could be punched up a little bit, and perhaps even use the same color coding as the blue to indicate that it's being pulled. I think that would be helpful. The other comment I had, and again, as everybody else has said, I feel like, I mean, my goodness, this is one of the most challenging surgeries I've ever seen, and the layering and the transparency is so effective. And between the two retractors, I think you could use just a little bit more of the same treatment so that the tumor that's kind of showing through transparently isn't confused as being some other structure that's still like, you know, it's the transparency of the tumor that's showing through to it.
Thank you, Jenny. Thank you so much for your comments and feedback. And now I would like to introduce our next speaker, Gabby.
There you go. Thanks, Tina. Good evening, everyone. Thanks for hanging in there. I'm Gabby Rivera, and I'll be the last speaker for tonight. Without further ado, my presentation is for a reverse total shoulder arthroplasty, as performed by Dr. McFarland. My thanks to him for the opportunity and for his comments and attention throughout this process. We begin with the patient in a beach chair position to accommodate a deltopectoral approach. Here I've marked down some important neurological structures that one has to mind during the procedure, particularly the axillary and musculocutaneous nerves. An incision is made from the clavicle above the coracoid process, also called the lighthouse of the shoulder, down to the axillary crease. The cephalic vein is revealed by blunt dissection, marking the deltopectoral interval. Once the deltoid muscle and cephalic vein are retracted laterally, and the pectoralis major muscle medially, a few things have to happen. A, the pectoralis insertion, at least the top third portion, is released. In B, the humeral circumflex vessels, also called the three sisters, are ligated. And C, the long head of the biceps is released from its sheath and cut superiorly. The conjoint tendon is then retracted medially, careful to avoid damaging the musculocutaneous nerve, which passes through it. We can't see it here, but we know it's there. And the subscapularis is then released. A capsulotomy is performed, and now we have reached the glenohumeral joint. This step was done together with the subscapularis release in the operating room, but I chose to depict it separately with the subscapularis tagged for clarity's sake. The humeral head is then dislocated, and the arm maneuvered for placement of an extramedullary guide. The cut is marked out and made with the arm in 30 degrees of retroversion. A and B show the intramedullary canal being progressively reamed. B in particular shows a cutaway as the reamer width hits cortical bone on either side. In A, the humeral brooch is inserted. Had fun with that. And now in B, as our attention turns to the glenoid, a cap is placed to temporarily protect the cut surface from instruments. After the soft tissue is debrided, a pin is inserted into the glenoid with the aid of a guide, and the surface reamed flat. A, B, and C depict the consecutive parts of the glenosphere prosthesis. In A, the base plate is screwed in. In B, the peripheral screw is then placed. In this case, the medial screw was omitted because there wasn't sufficient bone to secure it. And finally, C shows the glenosphere itself. You'll note the inset on the bottom shows the full thing put together. Then the cup attachment is fitted to the humeral brooch. A fit test is done, and here's the end result. I chose to render the capsulotomy step, as I found it to be the satisfying conclusion to the process of carefully peeling away the muscular layers to reach the joint itself. I was encouraged to render in full color and employed didactic coloring, such as the blue for the two veins that make up the three sisters, as well as the goldenrod axillary nerve passing inferior to the humeral head. I also used a saturation and vignetting technique to focus the viewer's attention on the point of action. I now leave the floor open for comments and questions. Yes, Jenny?
I just want to compliment you on your gorgeous technique. I love the saturated color and the focal detail that you provided to the audience. It's just very well executed.
Thank you. Yes, Tim?
Very much the full color that you've given us in the area of action and the very nice accented outline to the shoulder, the arm, that area, just kind of remind us where our landmarks are and how to bring us into the center of the action.
Thank you. Alrighty. If that's, Juan?
Just a quick note of comment that I like your nod to diversity.
Thank you. I try to do that in my pieces. Yes?
So on ABC, we were supposed to talk about accuracy, clarity, but also the presentation. I enjoyed the presentation because it included a clear appreciation for what was going on in anatomy, but also some of your personality. I don't even know you. I like the presentation.
Thank you. I think that's a good place to move on to my next presentation. Keep them wanting more. And finally, because we love a good bookend, I'll take us back to the kidney with a laparoscopic radical right nephrectomy as performed by Dr. Patel. I thank him as well for his time and attention throughout this process. The patient was found to have a large mass on the superior pole of the kidney, necessitating a radical nephrectomy. To start things off, the patient is placed in left lateral decubitus and ports placed as shown. The colon and duodenum are then mobilized. A depicts the dissection along the white line of Tolt, and B describes a Coker maneuver to drop the duodenum, apologies. The result of which can be seen here. Blunt dissection of the inferior surface of the kidney is done to identify the ureter and gonadal vein, using the psoas muscle as a guide. The renal hilum must then be skeletonized thoroughly, and the renal vasculature then stapled. The arterial supply is transected first to avoid congestion and to collapse the vein. In this procedure, the adrenal gland was spared. This began after transection of the superior renal artery. First, the peritoneum and then the perirenal fat are dissected into the area circled above in red, called Morrison's pouch. The ureter was then clipped and transected, and the remaining renal attachments dissected as well. A hemostatic dressing was then applied to what was left of the renal hilum, and the kidney placed in an endocatch bag. Finally, the specimen is removed via an incision along the linea alba. This particular method ensures easier healing than if the cut was made to the abdominal muscles. I chose to render step 6 again, the transection of the renal hilum, as it was a significant surgical moment. I did take some liberties and pulled back the perirenal fat around the tumor to expose its surface. I pulled the view back a bit as well compared to what you would normally see in a laparoscope at this point, so that we can appreciate the anatomical landmarks. I decided on a rendering style inspired by the reputed medical illustrator Bill Andrews to focus the viewer's attention to the point of action, particularly the powered vascular stapler mid-cut on the renal vein. The central lighting mimics the light of a laparoscope. I now yield my time for comments and questions. Yes.
Well, I'm just gonna repeat myself. Gorgeous use of color, incredibly didactic and very clear. The only critique I have is that if this is for slide, it's still a little bit hard to read the labels, so a little more contrast there. But again, I just love the paper kind of showing through, and just the technique that we've used is just so effective.
Thank you. All right. Oh, Juan.
I just want to comment that the line work on the sketches was so professionally done, and also very simple and beautiful, and felt like I wanted a copy of it so I could color.
If you'd like, I can give you one. All right, thank you for the comments and questions. Thank you, everybody, for joining us today, actually. We'd like to take the time for some acknowledgements. Firstly, to the Art as Applied to Medicine faculty for their help and guidance, and of course, the inimitable Daisha Balch and Jeff Day for making this live stream event possible. Our thanks to the surgeons who let us observe their work, collaborated with us as we rendered, to the operating room staff and nurses who accommodated us, and to the friends and family joining us today.
Thank you all for coming. It's very moving to be back in Chevy Chase in person and in the hybrid mode, having lots of people join us for the live stream. Thank you all for your comments, and I hope everybody has a happy and safe holiday. Thank you.